Okay, let's talk about Asherman syndrome. The first Asherman syndrome is described by Joseph Asherman. It is also called as amenorrhea traumatica. Intrauterine adhesions or intrauterine synecdoche occur when adhesions form inside the uterus with attachment of endometrial lining of the uterus. Occur primarily after, what are the etiology of the Asherman syndrome? First one is it usually occur primarily after vigorous dilatation and curettage. The indication, usually you are doing elective termination of the pregnancy, miscarriage, incomplete miscarriage, written product of conception. For non-obstetric indication, we are doing dilatation curettage like heavy HMB, AUB under evaluation, sampling to rule out endometrial cancer, removal of endometrial polyp. What are the other causes like myomectomy for uterine fibroids, endometrial ablations for menorrhagia, abnormally adherent placenta in pregnancy? If you going for manual removal of the placenta, developing country, tuberculosis, schistosomiasis also a cause for Asherman syndrome. Dilatation and curettage for RPOC carries the greater risk of for Asherman syndrome. Dilatation and curettage in the first and second postpartum week carries the greater risk for Asherman syndrome. Pathophysiology of Asherman syndrome occurs when trauma to the basal layer of opposing endometrial area in the uterine cavity. Adhesive bands form from one side of the uterine cavity to other. Abnormality in the placentation, where the placental tissue burrows below the basal layer of the endometrium, that will significantly increase the risk of developing Asherman syndrome. The pathophysiology is if there is a trauma to the basal layer of opposing endometrium area in the uterine cavity, adhesive bands form from one side of the uterine cavity to the other. Abnormality abnormality in the placentation. Abnormality in the placentation means the placenta tissue burrow below the basal layer of the endometrium, that will significantly increase the risk of developing Asherman syndrome. The adhesive bands are not usually vascular. The extent defines whether the case is mild, moderate or severe. The lesion can be thin, thick, spotty or confluent. What are the history you are taking? Typically the patient is present with hypomenorrhea progressing to amenorrhea. The hypomenorrhea lasts less than 22 days and less than 50 ml bloods. Normal previous volume blood is based on the surface area affected. The pain complaint, no bleed, severe pain around anticipated periods that becomes, if it is endometrial build of adhesion near the cervix, then the endometrial tissue could not be come out, so that will cause us pain. Infertility, usually they present infertility with recurrent miscarriage, that is equal to deficient endometrium. Physical examination is insignificant. Blind cervical sounding may reveal cervical obstruction at or near the cervical os. How will suspect intrauterine adhesion when no bleeding with estrogen and progesterone withdrawal challenge test? After giving estrogen plus progesterone challenge test for 10 days and hormone profile, if hormone profile is normal FSH LHE2, then you have to suspect Asherman syndrome. Is Asherman syndrome is where the HPO axis is completely normal. Okay, these are the HSG finding. Typically you are getting this feeling defects. Okay, this is also Asherman syndrome typical feeling defect. Okay, 2D TVS. In the TVS, there is a, what are the interrupted endometrial line in the sagittal plane. This is the interrupted endometrial line in the sagittal plane. Punctate echogenic foci in the endometrium. Interrupted line, punctate echogenic foci in the endometrium. Indistinct endomyometrial junctions. There is no distinct endomyometrial junctions. Punctation, punctate echogenic foci, interrupted endometrial line, and thin endometrium that does not increase with hormonal therapy despite normal ovaries and hormone profile. The endometrium that doesn't increase the hormone, that the endometrium that does not increase with hormone after giving hormone therapy also, that is not responsive despite you have a normal ovaries and hormone profiles. How, what are the finding in the 3D ultrasound? You will get irregular endometrial cavity outline within coronal plane, decreased endometrial thickness less than 2 mm, interrupted endometrial line, Undetectable endometrium suggests an extensive adhesions, narrowing of endometrial cavity, transcornual diameter of less than 20 mm, mid cavity diameter is less than 10 mm. Okay, so what are the 3D ultrasound finding? Irregular endometrial cavity outline in coronal plane, decreased endometrial thickness that is less than 2 mm, introfted endometrial line, undetectable endometrium suggests extensive adhesions, narrowing of the endometrial cavity. Cavity should narrow, there is filling defect, there is transcornual diameter is less than 20 mm, mid cavity diameter is less than 20 mm. Saline sonography can demonstrate hyperechogenic band adhesion across the uterine cavity. If you are doing a saline sonography, you can get a trans hyperechogenic band of adhesions you can across the cavity. Remember, these are the very good things if you are going for a saline infusion sonography. Okay, if you are doing a saline infusion sonography, you can demonstrate a hyperechogenic band of adhesions across the uterine cavity. Here also you can see an hyperechogenic band of adhesion, hyperechogenic band of the across the uterine cavity. Remember, these are the very important points. How to diagnose? The guideline for the diagnosis of intrauterine adhesion, the hysteroscopy is the most accurate methods for diagnosis of intrauterine adhesion. Should be the investigation of choice when available. If hysteroscopy is not available, HSG and a saline hysterography is alternative. Magnetic resonance imaging should not be used for diagnosis for intrauterine adhesion outside clinical. So mainly you have to go diagnostic hysteroscopy plus or minus adhesiolysis. Okay, if it is not available, you go for a HSG. If that is not available, you go for saline hysterosonography. Okay. Staging: the American APSS classification the severity of the disease in 3 stages: the mild, moderate, severe. Few filmy adhesions involving the less than third of the uterine cavity. It is involving less than 1/3 of the cavity with normal menses or hypomenorrhea. There is grade mild disease. If filmy and dense adhesion, the involve 1 to, if it is involved 1/3 to 2/3, this is moderate plus hypomenorrhea. Okay, if it is less than 1/3 with normal menses or hypo, if it is 1/3 to 2/3 involvement, moderate to filmy and dense adhesion with hypomenorrhea, it is called as moderate disease. If it is a severe disease, the adhesion involve more than 2/3 of the cavity with amenorrhea. Okay, the management of Asherman syndrome, you remember the Asherman syndrome, usually you do hysteroscopy, experience laparoscopy guidance, scar removal procedure, preoperative intra post-op estrogen, promote regeneration of the endometrium, reduce the scar formation of post-op. Device to prevent apposition of uterine wall, copper containing ICD helpful. Unintended risk of atrophy due to pressure from the device. 4 option after hysteroscopy adhesiolysis. No treatment you can give, or you can give a estrosel alone therapy or estrogen plus copper containing IUD or copper containing IUD alone. Whatever treatment we can give. Okay. The hysteroscopy treatment enable lysis of the intrauterine adhesion under the vision with magnification. The uterine distension is required for hysteroscopy. May it's a lyse mild adhesions. Blunt dissection may be performed using only the tip of the hysteroscope. The more lateral the adhesions, greater the density, more difficult the dissection, greater the risk of uterine complications. Monopolar and bipolar electrosurgical instrument, Nd:YAG laser have been used. Advantage of energy: precise cutting, good hemostasis. A disadvantage: potential visceral damage, peritoneal perforations, further endometrial damage, predisposition to uterine adhesion. Cost: degree of cervical dilation required to accommodate operative instrument. Precaution to avoid perforation: transabdominal ultrasound to guide the hysteroscopic revision of uterine adhesion, e.g. availability of ultrasound. And laparoscopic guide reported to aid hysteroscopic revision of severe uterine adhesion. Pelvic organ. Treatment of internal ablation. Use cervical dilator sequentially directed from the cervical canal toward the ostia. The created 2 lateral landmark of central fibrous septum. This divided transcervically with hysteroscope under laparoscopic guidance. Non-hysteroscopy methods of treating intrauterine adhesion. Dilatation and curettage for Asherman was the primary mode of management before the widespread use of hysteroscopy. With the availability of hysteroscopy, dilatation should be not be performed. Accurate diagnosis, classification, and not further damage to endometrium may occur. Laparotomy, hysterotomy, and subsequent blunt dissection through adhesion using finger or curette. In contemporary, this method is rarely used. Reserve only severe cases which other techniques are not practicals. The guideline for the surgical management of intra-adhesion hysteroscopy lysis adhesions by direct vision and a tool for adhesion lysis is the recommended approach for the symptomatic intra-adhesion. There is no evidence to support the use of blind cervical probing. There is no evidence to support the use of blind dilatation curettes. For women with intra-adhesion who don't wish any intervention but still want to conceive, expectant management may result subsequent pregnancy. However, the time interval may prolong. Adjunctive intervention at adhesion lysis include ultrasound, fluoroscopy, laparoscopy. No data suggests that this prevent perforation improves surgical outcome. In the presence of extensive dense adhesion, treatment should be performed on expert cystoscope familiar with the methods. Semi-solid barriers, gel adhesion barrier, reduce the risk of recurrence after surgical excision adhesion. Auto cross-linked hyaluronic acid gel, high sensitivity, stay for a prolonged time on an injured surface such as post-operative endometrium. Post-op ultrasound studies demonstrate the wall of the uterine cavity remains separate 72 in this group. Technique to increase vascularity, we can use aspirin, nitroglycerin, sildenafil. Number of women treated remain also available.